Greetings, this is John Gruber, going to do a case study on gout. I'm going to time this out. I know this little part here is not going to be part of my time. I'm limited to 25 minutes. I have a timer set for 5 minutes. It will go off several times. You may or may not hear it during the presentation, but it's just to help keep me on pace. And we're going to go ahead and get started. I appreciate y'all's time. Okay, so my case study is about the disease process of gout. It's by John Gruber. This is for HS 771_DE. That is Advanced Pathophysiology under Professor Pearson. So we'll start off by doing a systemic review of joints, just generally sort of understanding a little bits and parts of it. So as far as joints go, we know that they typically involve capsules that contain cartilage. There are other connective tissues, such as ligaments, and that those tissues will actually connect the two bones together, which allow them to move. There is a limited degree of movement based upon the kind of joint. So I added a little picture for you here of different kinds of joints, like gliding joints, the hinge, the pivot, ball and socket, saddle joints, all that sort of stuff. So wanted you to see that, just to remind you that there are several kinds, and that the degree of movement is limited based upon that structure when the joint works the way it's supposed to. Now, as far as joint capsules go, we can see in the diagram here to the side where my mouse is that there is actually a blood vessel right next to a nerve that's going into the capsule itself. So the capsule is fed by blood in the sense that the wall of the capsule is fed by blood. The thing is, though, is inside this capsule there is a fluid membrane. That fluid that is helping lubricate and protect the cartilage that separates the two bones carries the nutrients that feed the cartilage, and in part, and also feed some of the inner surface of the joint space itself. So there is a blood vessel. We do have blood flow, but there isn't a lot of blood flow. So it is something to bear in mind as part of this disease process and why we have an issue in the joints when this process is a systemic problem. So we'll go ahead and move forward from there. Now, I also want to review renal function here. So just like we talked about in the past and in previous sections, the functional unit of the kidney is the nephron. I've got a nice picture for you here that shows all the little pieces and parts. There's a little blow up of the Bowman's capsule here. So we have an artery that goes in. There's a bunch of loops of capillaries. And then you have an efferent arteriole that actually goes out. And we can see in the larger diagram here that actually connects down to and runs past a lot of the other structures where the filtration process occurs. So we know that the components of the filtrate actually leak out in the Bowman's capsule here in the glomerulus. They come down through the proximal convoluted tubule, and it goes bing, bing, bang through all the stuff. And we see that there are these loops. Now we have large loops and small loops. For the sake of time, I'm not going to compare the two or what individual processes are. But I do want to remind you that the main function of the nephron is to filter fluid, electrolytes, nitrates. There are some proteins. If we see larger proteins, it does concern us, but the general filtration process, as well as other metabolic wastes. The nephron's role and thus the kidney's role in the issue of gout is very important. I do want to turn your attention to the JGA. So that's the juxtapositional glomerular apparatus. And that is the area where we decide the quality of filtrate. So that's where, not the decisions are being made here. There's no, like complex nerves or anything here, but essentially there's a sensation of, okay, we need to make adjustments to the urine. That's going to be coming out because we're trying to retain certain products. And a big one that we talk about is the fact that the JGA produces renin. That cleaves angiotensinogen, which is made by the liver and kind of flows through the blood freely. Once it's cleaved to angiotensin, then that allows a cascade of a series of enzymes to cleave each other in different spots. Again, I'm simplifying this for the sake of time to where we get to where we're activating aldosterone. Now, aldosterone is very important because it causes us to retain sodium. And wherever sodium goes, water goes. It's a big part of what we learned about how the kidney functions. And so you run into a situation where you have an increase in blood fluid volume and an increase in blood pressure from that. So the worry that we have is if nephrons get damaged. If we can have scarring in the glomerulus, which again is this little body right here, beep, 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 just there. There's one there, that little pink ball there. And when that happens, it inhibits filtration. But if we have damage to other tubules and even damage all the way out here at this end, then we have a situation where we're inhibiting the process of absorbing, so resorption, pulling stuff out, and then also putting excreting different solutes that need to be excreted. So the question is, well, how does that relate to gout? And to do that, we'll first talk about, essentially what gout is. So gout occurs because there's an excess amount of uric acid. Uric acid is a byproduct. It is broken down. It's actually a protein that gets broken down, specifically a class of proteins called purines. There's a bunch of them. They do a bunch of stuff. An easy example of a few purines are guanine and adenine. You might remember those from components of DNA. Now, there are foods that are high in these purines, and if we eat a lot of those or we don't process those well, then a byproduct of breaking things down produces a large amount of this uric acid that we're talking about. So I got a nice graphic here. It talks about some options that are good for people to eat and some things that they really should avoid. So big ones that we want to avoid are a lot of fermented products. The Marmite there is kind of like that Vegemite sort of stuff. It's like a yeast product that comes from making beer, really popular in Australia, not so much in the US. We have beer that's fermented. We have red meat and organ meat. So we have liver, kidneys. Red meat is on that list, so steaks are out. And then there are some seafoods, not all seafood. Salmon is a concern, tuna. If you like anchovies like I do on pizza, that is also a concern. And then there are other seafoods and shellfish that can be very, very high in purine. So we worry about people who are eating that sort of stuff, especially if they have trouble processing uric acid. Now, at the end of the day, when uric acid is being processed, it turns into this, it actually turns into a salt. It's monosodium urate, which is MSU. You'll see me use MSU a bunch of times throughout here, and that's all it means. And so what we're really worried about is how MSU is deposited within the body. And I have an example of where these uric acid, this MSU, forms these little crystals. And you can see right there on the great toe, very, very common place that this happens. The joint that actually attaches essentially your big toe to your foot, the metatarsophalangeal joint of the great toe or the hallux. Now, so we look at why this happens. You'll forgive me, I'm trying to get this thing to pop up here, to go back up here. Okay, so why is processing uric acid difficult? So uric acid, like I said, is a byproduct. Now animals, regular old animals, they actually do a really good job of processing uric acid. They typically don't have problems that we do with this disease. Now, this is a medical class. This isn't like a study of animals or anything, but it is important to remember because animals do actually have this enzyme called uricase. We don't have that. Primates don't have that. Human beings are a kind of primate. We don't have that. So we don't actually make this. And there are actually a few other enzymes as well that we don't make. But essentially, you can see in this graphic here that there are, if we eat a bunch of simple sugars or alcohol or, purine-rich foods, that there's this complex process, this, HG, PRT, and, a bunch of other enzymes where you produce a series of products, and the end result of that product is uric acid. And it's excreted mostly in the kidney, 70%, also in the bowel, 30%. But the big deal is the kidneys. That's where we have most of our stuff. Now, as far as variance goes, there are some humans that have an anomaly of their HG-PRT enzyme. It's an X-linked trait, so unfortunately for us men, it tends to affect us more, and that can cause really poor excretion of uric acid, so that is a concern. Now, another concern is a cultural thing, so the Western diet that we worry about. The Western diet has a lot of purines. We eat a lot of red meat. We eat a lot of protein in general compared to a lot of populations, and so, that is a concern for us long term. Now, we talked about how alcohol is involved here. Essentially, the enzymes that process alcohol process some of the byproducts for other drugs and chemicals and medicines that end up resulting in some of the byproducts for uric acid. So if we have a bunch of alcohol, we end up with a bunch of uric acid, which is why they're related. Now, the big deal with this is that elevated uric acid levels, or hyperuricemia, that's a fancy word for it, can cause kidney damage. Damaged kidneys don't process uric acid well, so you'll have more of it in your blood. But at the same time, elevated uric acid levels damage the kidney, so it's kind of a cyclic sort of thing that happens. And we can see how that, if you have this feedback mechanism where one's making the other worse, how folks that have problems with chronic kidney disease, it would be an issue, which is why we talk about the kidneys, and then we're also going to talk about deposit in the joints. So what we end up doing here is we worry about some drugs as well that affect the way that the kidney functions. It does affect our ability to process uric acid. An example is thiazides. We do worry about those and your ability to excrete uric acid, and that may be a culprit. So now moving on to joints, because it is an important topic. We ask, well, why do we care about the joints? So these MSU crystals that I'm talking about, the uric acid, they actually form deposits in tissues. The process is really, really interesting. So part of it is that the synovial fluid, these crystals, and in general, the MSU particle, if you want to call it that, is a lot more soluble. So it flows out of the vascular tissue that feeds the capsule of the joint, and it doesn't like to go back in. It's a lot more soluble in that than it is in the blood, so it kind of leaches out of there. And it'll accumulate, stay in the joint, and stay there as in stay there permanently. So one of the concerns we have is when we have a large amount of MSU that deposits in there. And what will actually happen is macrophages will notice that this is there, they'll swallow it. And they make this funny structure called an inflammasome. And I think of it as like a little shard of glass. Like you see where my pointer is, the crystals in synovial fluid, these little like shards of glass. Those will actually be excreted once the macrophage destroys itself. Now, before it does that, it produces all these factors here that recruit more macrophages, other phagocytic cells, and it actually produces some inflammatory communication chemicals as well. That's going to cause damage to the nearby tissue. So we have increased inflammation. And then when they burst, we have these crystals. So we have inflammation plus bursting. The bursting of these crystals causes them to be deposited in the joint. That's painful in and of itself. So we have kind of a double dose of inflammation here. And the worry that we have is that there's a release of this TNF alpha, chemokines, interleukins, and some other stuff. And that's just more of the big fancy words to talk about the local inflammation and damage that happens in joints. And it is a progressive process. Now, I talked about how you can see some of that stuff. We can actually see here on where my pointer is and where the little arrow is, there's actually a divot out of that joint. That divot is representative of destructive changes to the joint that happen. This is a long-term process. This person's probably had gout for a while. They probably had multiple episodes of gout in that particular area. And we can actually see in the tissues that surround the joint capsule, not in the joint capsule, but the tissues that surround it, you can actually have a development of those crystals as well. So much so that they make this kind of cheesy sort of material called tophi. And the C right here, this little picture that I'm showing you with these white sort of crystal bumps in there, you can see where it is. Now, the graphic does have some more details. Like I said, there's a lot of stuff to talk about here. So I included that to kind of skip over having to go through some of these individual pieces of parts. So why do we worry about renal? Well, it has a cause renal damage. That's what we worry about here. So the crystals can actually deposit themselves in the renal tubes. And we can see different parts here, how there are, that the deposition causes basically an inflammatory process, and that can cause modification and kind of restructuring of the way the glomerulus itself and also the tubules are shaped. And that affects their ability to do their excretion job. And it also affects the ability for flow of the filtrate, flow of blood, all that stuff to go through there. And so what we end up with is kidney damage. And a big way we can also see that is these crystals can form actually outside of the glomerular process, and they form inside of the tubules themselves, where they can form renal stones. So the book says it's 1,000 times more likely. That's a lot. whole lot. And if we do have stones, then we have obstruction. And if we have obstruction of those proximal tubules, then you have swelling and inflammation. That swelling and inflammation causes remodeling to occur. You can have acute renal injuries and then chronic renal disease that's caused because of these changes. I actually found a paper that talked about this, and they explained that as many as 30% of patients with chronic kidney disease actually have issues with hyperuricemia. So that's that extra uric acid that I'm talking about. It is cyclical. As the kidney gets more damaged, it doesn't process uric acid well. Uric acid crystals build up, they damage the kidney, so your kidney disease gets worse. And this is a progressive process that, frankly, we really don't know how to solve very, very well. There's arguments back and forth about what medicines to use and why and how, and there are a bunch of papers on the subject. And I included a nice graphic for you. So this is actually what a kidney stone looks like on a X-ray. This is a Staghorn calculus, so it's a big one. This is blocking off a large portion of that kidney, and there's going to be a lot of damage going on in there from all the pressure. So let's see, common findings that we have here. So we can see that one of the most common places people have it is at that MTP joint that I was talking about. I have a nice picture of this lady with her really desperately need to be repainted toes. You can see the redness, the swelling that's going on there. I have a knee for you that shows that, and you can see that little hole there at the bottom. I guarantee this person has gouty tophi. That's probably an area where it's either burst through or they've actually punctured it themselves. So these gouty tophi can land a lot of places. I don't want you to think it's just a great toe prop. There's an example of the knee. There's an example of the fourth toe there, the bottom corner. And you can see that bloody, cheesy material that's coming out there. So it's a mixture of those crystals that's like this chalky, cheesy kind of material. And then there's some blood and fluid, the serosanguinous discharge. So it's a mixture of both. And you can see how red and inflamed these are. This example up here in the hand shows all these deposits just all over the hands from years and years of these episodes occurring. And we can actually see how even when there's not redness or necessarily inflammation, that these deposits can occur. And that's what these little like pearls are on these joints. So if you see that, even if they're not complaining of it, you can guess that they probably have gout. Now, a big thing that happens is because of the swelling and the redness and all that stuff, there'll be a lot of sensitivity to light touch. People that come in with a great big swollen toe like this, they probably won't be wearing shoes when they come see you. They'll be wearing slides or some sort of sandals that doesn't press on it. It can be very, very painful, and there will be large changes long-term chronically in these joints, and you can actually see that on X-ray. So speaking of, I added some X-rays. I'll just point those out. You can see some things here and there. So those little blue arrows and the red arrow that I'm talking about show areas where there's been chronic changes and damage. Now, the second X-ray is interesting. You can see these big white bumps, and these are those swollen areas that I showed you, like on the hands right here. This is not the same person. I got this from a different source, but if you looked at an X-ray, that's what you would see. And this is just a cloud of these little crystals that are blocking the X-rays, which is why it looks all hazy right there. And everywhere where one of those are, there is some damage to the joint and the bones that are at the joint. So when we look at lab values, one of the things that we worry about is a situation where people have this elevated uric acid that's going on. Uric acid levels can run between 3.5 and 7. I've got the units for you just so you can see them there, just so you know what they are. Most women don't really get higher than 4.5. It happens in women. Usually they have a lot of health problems going on along with this to kind of contribute, but the big problem is it happens in men a lot. And you can see why, because even a normal man that doesn't end up having gout or anything else, their uric acid level will rise to somewhere between 5 and 7 by the age of 30. Symptoms normally start after the age of 30. So you can imagine if they're high, and we worry about people who have uric acid levels above 7, that they can end up having this. So, the ratio of people that get this, men are 3 to 1 compared to women. At the same sort of time that we worry about targets for therapy, we actually want to get below a level of 6. So you can imagine if they're sitting between 5 and 7 on a good day, you can see why it would be very, very common for that to happen. And we actually want to get that level below what a lot of people naturally have, even if they don't necessarily have symptoms. Now, I made some more commentary on the X-ray stuff. This one actually is interesting. This is a CT of the kidney, and you can see these little areas where these crystals have formed and how thick the wall of the kidney is. I know that's radiology is not something we spend a lot of time talking about, but you'll just have to trust me. This shows some big-time inflammatory changes in the capsule of the kidney itself, suggesting a lot of damage. Now, what do we worry about for risk factors? There's no one risk factor that explains gout. Just there isn't. Sorry to tell you. The issue is that we know of a variety of risk factors, and what happens is people have multiple risk factors together. And so those risk factors together contribute. Now, we talked about the genetic issue. I won't hash that again. We talked about chronic kidney disease and why that's a risk factor. I won't hash through that again. We've also talked about intake of red meat, seafood, alcohol, simple sugars as well. The process of processing simple sugar actually messes with the ability of the way purines are processed. And so if you take in a bunch of sugar all the time, if you're fatty like me and you eat a bunch of sugar, then it can actually affect the way that you process uric acid. So obesity is a concern because of diet, and a lot of folks who are obese eat a lot of sugars and a lot of red meat, stuff they're not supposed to. Male sex for the reasons we described, diabetes. Because at the same time, if you have a situation where you have an excess of uric acid, it messes with your ability to process sugars. So if you have an issue where you can't process sugars well because you have poor insulin sensitivity, then you'll have increased uric acid. Same time, increased uric acid messes with your ability to process, your ability to be sensitive to insulin. So they're related. So things like metabolic syndrome, or sedentary lifestyle, where folks have these diets and poor sensitivity to insulin, they have elevated uric acid. So there are health risks related to gout, and by that I mean other things that can happen in part because you have gout. One of those is atherosclerosis. We talked about it a little bit more later on. Worsening renal failure, we talked about that already. And it's actually linked to, because of atherosclerosis, we're worried about coronary artery disease, strokes. And those are big time symptoms that people can have. Or big time disease processes that people can have that have a component of their elevated uric acid. And we also talked about kidney stones, and I showed you some nice pictures of that. So case presentation, we have to talk about the gentleman that we're going to be taking care of today. This is Mr. JH, 47-year-old male, history of hypercholesterolemia, hypertension. Note the hypercholesterolemia, that's a big deal. And then TIA 3 months prior. Remember our vascular issues we worry about, who presents to the PCP with a complaint of acute onset of pain in the right great toe since the previous evening. They're associated swelling and tenderness, as well as localized allodynia. That's just a fancy word that means it's so sensitive, even normal stimuli like touching it is something he can't tolerate. So he expresses his allodynia by explaining he can't put a sheet on it, can't wear a shoe, can't wear a sock. And he actually shows up to the office wearing slides because it's so painful to the toe. The discomfort's caused him difficulty sleeping, super, super common. This is really, really painful. And we can see the pain began after an extended birthday party celebration. So party time, probably some alcohol, some cake, lots of sugar, food. And that might have actually tipped him over the edge there a little bit. So there's no history of injury to the foot, so we're not as worried as much about something that's been chronically going on. Now, a review of symptoms: he does not have headache, dizziness, chest pain, shortness of breath. Always good. With his history, we would worry about cardiovascular stuff, so I would ask him no matter what. Makes sense. Shortness of breath as well, edema to extremities, and he doesn't have generalized joint pain, so I'm not worried about as much him having some sort of inflammatory general joint process like RA or something like that. Now, he has gained 15 pounds in the last year. Not great. We worry about that obesity and sedentary lifestyle stuff we're talking about before. And he doesn't deny his previous history of joint pain, so he's never had this before. If this is gout, this is his first time having gout. We'll see what we get. So physical exam. So white male, he's in acute distress, a lot of pain, open-toed shoes without socks. We talked about why that happens. His blood pressure's a little high. Heart rate's fine. Respiration rate's good. Temperature's 100.2. And, that is a little bit high. It is a fever. But, the thing is, he's got this big time inflammatory process and he's in a lot of pain. So I'm not super surprised his temperature's high, but not super high. It's not 101, 102, something like that. That makes me think, oh my God, he's infected. I could definitely tell he's got something going on now. So he's a big fella, 6'1", 225, BMI is 29.7. That's right on the border with being obese, technically. He's overweight, not obese, but, very close there. Now, neck and lymph, totally normal. No swelling, no thyromegaly, no masses, no JVD. And again, cardiac thing, we worry about JVD, so that's good. He's Perla, so pupils are equal around reactive to light with accommodation. 3 millis bilaterally, fundoscopic exam is normal. So basically, his eyes are good. Lungs, he's cleared auscultation. That's all the data I have on that to give you. I would have probably listed more about any sounds or what have you. His heart is regular rate and rhythm. There's normal S1 and S2, no murmurs, rubs, or gallops, so heart sounds good. Everything's kind of beating the way it's supposed to. Sounds like no murmurs, any of that sort of stuff. So I'm not worried about anything acute cardiac going on just based on the exam findings. Abdomen's non-tender, non-distended, bowel sounds are normal, no hepatosplenomegaly. The liver's a big area where uric acid is processed. A lot of these, processing sort of things occur, and then it's excreted in the kidney. So, if I don't have any signs that his liver's doing something funky, or his liver and spleen are doing something funky, then I'm less worried about it being like a liver processing sort of issue. Musculoskeletal stuff. So we got pulses of 2+ in all 4 extremities. That's good. He's getting good blood flow down there to that foot. So I'm less worried about some vascular issues. Strength is 5 out of 5. That's good. I'm not worried about a nerve issue so much. And then that right toe, right there at that hallux, that MTP, it's hot, it's tender, it's erythematous, it's swollen. Not good, not good. So we have neuro. He's ANO times 3. Basically, he knows who he is, where he is, what's going on. Cranial nerves are intact. That's great. No central processes that I'm worried about where his cranial nerves are effective. Deep tender reflexes are good. So he's got his reflexes. We're not worried about any kind of spine neural stuff. Babinski's is negative. So neurologically, he's fine. Now, labs and x-rays, we're going to talk about stuff here. And I've made a point of noting where some things are abnormal. So electrolytes are normal. Sodium is 140. Potassium is 4.2. Chloride is 106, which is borderline normal, but normal. And then we have bicarb at 27, which is fine. Fasting blood glucose is elevated at 120. Now, we talked about sugar and elevated sugars and insulin sensitivity, so that does worry me. Kidneys are good right now. So BU and creatinine ratio, 14 to 0.09, or 0.9. Both of those are within the normal range and fairly well within the normal range. So I'm not worried about his kidneys. Uric acid is elevated at 13.1, so super high. If we're looking for, if 7 is worrying and 6 is what we're looking for if we're treating somebody, 13 is, that's up there. So a little bit of worry there. CBC shows normal H&H at 15.6 and 47. That's pretty normal. White blood cells are elevated. Makes sense. He's got an inflammatory process going on, folks. So I'm not super surprised that his white blood cell count is elevated. Neutrophils are at 73%. That is also elevated. Again, not surprised. We talked about how neutrophils play a big role in trying to scoop up some of that uric acid crystals and, that inflammatory process involved with that there. Bands 3%, monocytes, lymphocytes, and all that stuff is good. So his SED rate's 15, which is borderline high. That's kind of a generalized inflammatory protein. And I'm not super surprised to see that that's borderline for him. He has a major systemic inflammatory process with his elevated uric acid going on, so not hugely surprised there. Though he has elevated cholesterol, his cholesterol is 189, which is technically normal. 200 is where we're worried about. We start getting worried about folks, but it is a little high. I don't have a distribution for you to see how he's doing as far as LDLs and stuff, but technically normal. And then 24-hour uric acid is 985, which is way above there. So we'd normally be looking for something that's like maybe 700 at the most, and he's all the way up at 985. So he's putting out a lot of uric acid, but it's a good thing because that tells me that his kidneys are doing their job. I'm worried that he's making too much uric acid, and though his kidneys are dealing with it, he's got a lot of inflammatory processes that are going on. So we shot a picture of it. And took a sample of the synovial fluid from the joint. So the picture shows that he does have soft tissue swelling, and again, that's inflammation that's localized, not just to the joint capsule, but the soft tissue that surrounds it, so I'm not surprised. Now, the joint space is normal. There's no erosions or sclerosis. So that tells me that, yes, he's having this process, yes, it's occurring, yes, there's inflammation, but this is not chronic because the erosion takes time. So he might have had uric acid that's been, high for a while, but, the processes as of late, his diet stuff and then this party, he's tipped over to where he's starting to deposit these crystals, and this inflammatory process has begun. So we take a look at the synovial fluid. We see a bunch of those MSU crystals, not a surprise. And then a large amount of neutrophils that have actually infiltrated into that fluid. Now, traditionally, I'd be worried about some sort of infection going on here, but again, we know that neutrophils play a big role in trying to absorb these MSU crystals. They explode, they signal their friends to come visit, so we have lots of neutrophils that are in this space. Not a huge surprise there. Okay, this is a lot of stuff. So I'll try to go through it in a relatively reasonable amount of time here. So basically what's going on is I've got some differentials. I'm worried about a gout flare, worried about, possibly septic arthritis. This is before we've done any kind of assessment or anything, before we've taken the sample of the fluid, just worrying about what's going on. If he had a wild party night where he got drunk, he could have, broke his toe and not realized it. So, okay, I'll give that to him. Maybe a cold fracture, dislocation, subluxation, something like that. And then I would also be worried about him having so much of that elevated uric acid that it causes an acute kidney injury. When I'm coming up with my differentials, I'm ordering my tests. So before I got any of those labs or anything, that's the stuff that I was worried about. And I can knock off a lot of the stuff. So I'm not worried about acute kidney injury because his BUN and creatinine look fine. I'm not worried about the occult fracture or dislocation because we saw the X-ray, and the X-ray shows that none of that stuff's going on. And again, despite there being the white blood cells, we know that infiltration process is pretty common for gout to go on there. Now his uric acid level is super high. So I'm worried about gout now. His 24-hour uric acid again shows that he's putting out a lot of uric acid. His kidneys are working their butts off trying to get this stuff out of there. But it is an inflammatory process, and he does make a lot of this uric acid. So the kidneys are doing the best they can, but they're obviously not able to keep up. Now my concern would be that if he's putting out so much of this uric acid that he starts making kidney stones or damaging the kidneys, that they won't be able to do their job as well, and then he could have a huge spike in the amount of uric acid that he makes. So that is a concern that I would be worried about there. Now, as far as other stuff goes, he has a lot of risk factors. Okay, so he's a truck driver. That means he spends a lot of time sitting on his butt. I know truck drivers work for a living, but you do spend a lot of time sitting down. That gives him poor return flow of venous blood and lymph drainage. He is borderline obese on top of that. He does have an excessive fasting glucose, suggesting that he's got insulin resistance on top of that. And, that stuff suggests that he has metabolic syndrome, maybe pre-diabetes or diabetes. And then his, self-reported diet, that he has a lot of these, that he eats a lot of red meat and other stuff, high purine foods, is concerning. So, we worry about this mechanism of oxidative stress where he's eating all these purines, he's producing all this uric acid. We have this oxidative stress and inflammation that's going on. And we worry about a situation where that oxidative stress helps solidify the cholesterol that's in the atherosclerotic plaques that are in his vessels. Okay, and when that happens, the concern that we have is that we have a situation where this person is trying to get rid of the stuff, but they can't. They oxidize into place, and then the inflammatory process of oxidizing it fixates that stuff in there with these fibers that get put out as a part of the kind of remodeling process there. So again, we have all these risk factors. Worry about this stuff. And he had the recent TIA. Now the paper that I found that talked about atherosclerosis and its relationship to uric acid showed that it's very, very common for a person, if they do have a TIA or a stroke or a heart attack or something like that, that they have gout either 6 months before or within 6 months after it happened. So there does seem to be a correlation between events that are atherosclerotic in nature and an increase in uric acid. Okay, so treatment. We got to figure out what we're going to do for this guy. Now, I'm going to give him colchicine for pain. Colchicine is a very common drug that's given for pain for folks that have gout. And then I want to give him something that's actually going to reduce the amount of uric acid that's in his blood by increasing the amount that's excreted. It looks like his kidneys are doing a good job putting it into the urine and getting it out of there, so I'm going to give him probenecid for that. I also want to do some lifestyle modifications. We're going to cut the alcohol, we're going to cut the purine-rich foods, and I'd actually like to put him on a diabetic diet because that's going to reduce the amount of simple sugars. My point is I'm trying to tip the system back over towards where he's producing a lower amount of uric acid, and we're helping him get rid of that uric acid by excreting it out of his kidneys a lot better. Now, I'd love to give him allopurinol. Allopurinol, it's a great drug, but the worry is that he's on thiazides for his blood pressure. He's also on aspirin. Probably as a cardioprotective mechanism, and you can't take those drugs the same time you take allopurinol. So, I'd love to give it to him, can't give it to him for that reason. And frankly, because his blood pressure control is tenuous at best, and he has these risk factors, I would be worried about changing him to a different antihypertensive. And on top of that, if I give him allopurinol, I can't add something to his antihypertensives like an ACE inhibitor or something like that. And frankly, I'd like to get him under better control, so we'd have to see. Now, as far as complications go, like I talked about previously, there is a concern for TIA, CDA, heart attack, stuff like that, and it is related to the inflammatory processes where uric acid contributes to increased atherosclerosis, right? So, we would be worried about that. Now, none of the drugs that we have actually treat gout as in cure it. So what we're doing is management here. Now, the probenecid can help manage this. If he has, if he makes the changes that I'm talking about, that would be good. But I would actually also like to do something that's going to help protect his kidneys a little bit. So his blood pressure is a little high. I'd like to give him an ACE inhibitor because we can do that with probenecid. That's going to give him a little bit better blood control, and it also is a renal protectant, very commonly given for its renal protective properties. So I'd want to give that to him too to see if we can't knock his blood pressure down a tear and also protect his kidneys a little bit. Now, the worry that we have for colchicine is that it is pretty strong. It has a low therapeutic index. So we worry about him having, GI damage, diarrhea. He could actually go into organ failure if he doesn't take this right. And to me, if you're spending a lot of time on the road, it's really hard to just stop and sit down and take your drugs the way you're supposed to. So, I'd really, really want to do some good teaching for him, try to explain, listen, you need to make this stuff a priority. You need to hydrate well. And I know that's hard because, you have to stop and go to the bathroom, and we're going to have to figure this stuff out because he's got a lot going on here. Now, as far as progression goes, gout has basically 4 phases. Essentially there's a phase where you have elevated uric acid without symptoms, and then you have your first gout flare. And I think this is where this gentleman is at. He's had his first gout flare. After that, there's a resting period, and then you'll start getting flares. Those flares become more common. You start getting those gouty tophi, and then that process kind of snowballs from there. So my worry is that if he gets to the point where he has tophi, then he's going to have this stuff bursting out here and there. It is a source of infection locally, and frankly, again, if you have that uric acid that's elevated all the time, you have an increase in the atherosclerosis. He's already had a TIA, which is a concern because TIAs are a warning sign for a future CDA. And to be perfectly honest with you, I would be concerned that his ultimate end point would be that he's not going to keep his stuff under control the way he's supposed to. That his tophi and pain is going to limit his activity, limit his ability to protect himself from cardiovascular problems, and that could cause him to die. So that's kind of a summary of the treatment, complications, and progression there. So we should be all square here. I have scholarly references here. These are all 6 papers and books and stuff that I use for this. I put little references in there. You probably saw a bunch of A, B, C, D, E, F all throughout that, and those were references to the particular topics where I found this stuff. And then lastly, I have this media references page. There are tons and tons and tons of pictures and stuff that I use. I put in the copyright disclaimer because this is being used for educational purposes, but I did want to include the websites where I found this stuff to give people credit for what they did. I did actually pull a couple of photos from the 2 books at the bottom that I referenced previously in the scholarly references, and so I put those in there as well because I want to give them credit for the pictures that they have. And let's see, that should be about everything here. I'm going to stop this recording, and it was a pleasure. Thank you so much.